Dr. Asim Basha to start with the Kharat, please.
Assalamu alaikum, everybody. Surah Rahman, chapter number 55. A'udhu billahi minash shaitanir rajim. Bismillahir rahmanir rahim. Ar-Rahmanu allama al-Qur'an. Khalaqal insana allamahul bayan. Ash-shams wal qamar bihusban. وَالنَّجْمُ وَالشَّجَرُ يَسْجُدَانِ وَالسَّمَاءَ رَفَعَهَا وَوَضَعَ الْمِيزَانَ أَلَّا تَطْغَوْا فِي الْمِيزَانِ صدق اللہ العظیم. شروع کرتا ہوں اللہ کے نام سے جو بڑا مہربان نہایت رحم والا ہے. رحمان جو قرآن سکھایا، اسی نے انسان کو پیدا کیا اور اسی نے بولنا سکھایا. آفتاب اور مہتاب حساب سے ہیں اور ستارے اور درخت دونوں سجدے کرتے ہیں. اسی نے آسمان کو بلند کیا اور اسی نے ترازو رکھی تاکہ ہم تولنے میں توجہ نہ کریں. صدق اللہ العظیم.
Thank you, Dr. Bashabhai. Dr. Altaf, it's all yours. You can begin. Thank you very much. I'm going to mute myself as well.
Yeah, Assalamu alaikum, everyone, and I'm blessed to be here today, and mashallah, in the Global Dental Professional Group, and I'm thankful for them. And basically, today's topic will be focusing on the single tooth parameters in implant dentistry, which I'm going to demystify. Most of you know the protocols of implant placement, but I'm going to touch base the basics on the implant placement as well as the surgical aspects, because implants are prosthetically driven. We are always here to demystify the concepts of surgical procedures relating to the prosthetics. The reason for this topic today is for a single tooth replacement in an aesthetic zone is more complicated than placing a full mouth rehabilitation or placing full mouth implants and doing the prosthetics. The reason why I'm telling you this is aesthetic is more challenging, and in the aesthetic zone we are more concerned about the prosthetic outcome and the end result for the patient. When anybody wants to start an implant practice, he'll be starting only on a single tooth parameter. He will not go for a full mouth before he jumps from a single step to the follow-on steps. So I am thankful for again the GDP and the other people who are there in the panel, and Dr. Arif Akmal is my close friend, and we are conducting a lot of programs on implants. So, and now entering into the implant criteria.
Sorry, Dr. Altaf, if you don't mind, I do apologize. Your voice is not very clear, so if you could get the mic a bit closer and speak, if you don't mind, please.
Yeah.
Thank you.
Now it's clear?
Yeah, I presume so. Please carry on. Sorry about that.
Assalamu alaikum again. And today I'm going to talk about some of the introductions into the single tooth implant concept, and then the goals why you have to do a single tooth implant for a case which has got a single tooth missing teeth, and diagnosis and treatment aspects, the single tooth protocols, anterior and posterior biomechanics, and conclusion. Conclusion will be with the takeaway message, which I'm going to give you a clinical tips. So implant dentistry is more over, it's based on step-by-step protocols and biomechanics, and it's very much predictable. Predictable means the goal of modern implant dentistry is to return to patients the oral health in a predictable fashion. What is this predictable fashion is, you can help the patient to serve the patient in a treatment concept where the final outcome for the patient should be beneficial. Implant dentistry is not a rocket science. So be rest assured that you can practice implantology because The reason is you people are doing dentistry. You're doing extraction. Extraction is an extreme procedure, but implant dentistry is a very, very, very simple procedure in a surgical concept. I'm not talking about the advanced surgical procedure. I'm talking about the single tooth implant placement. It's not a rocket science. So implant dentistry should always have a total authoritative values of dentistry. See, I believe that implant dentistry should be made as a profession on its own. We should have a complete knowledge about the implants, surgical skills, prosthetic hands, caring fingers for the patient's compliance. We have lots of other concepts which will be very advantageous for you for implants supporting dentures, implants supporting single tooth implants or crowns. The reason for this is the bone maintenance, the restoration and maintenance of occlusal vertical dimension, facial aesthetics, and improved phonetics. When you give an FPD, you have to cut 2 teeth. I'm going to talk about the advantages once I'm entering into the advantages concepts of single tooth implants. So when we are improving the occlusion, reduced size of your prosthesis. You're not cutting 3 teeth or 2 teeth and then giving a FPD. So to eliminate the alteration or the mechanics for the adjacent teeth also is very favorable for the patient. These are the knowledge what you have to give it over to your patient. So all the patients should be well informed that what concepts you're going to do and what you're going to do for the betterment of the patient. The goal of modern implant dentistry is to restore the patient in normal function, normal counter function, aesthetics, health with a decisive diagnosis and treatment planning. This was given by Dr. Shankar Iyer. He always believes that you should always begin with the end in mind. So all the famous structures like your buildings, your Burj Khalifa or Taj Mahal was first of all planned before you started your treatment aspect or before you have made that structure. So implant dentistry is prosthetically driven. So almost all creations, whether it's the art, buildings, teeth, require the end result to be visualized and precisely planned for an optimal result. So when I'm talking about something related to a concept where you are going to see the patient from starting to end, there is something called as a triage or a triangle of success. What is this triangle of success? First of all, you have to have a clinical diagnosis, evaluation, case history taking and concern taken from the patient as the patient enters your clinic. And this is done for all the other procedures also. So clinical evaluation in a surgical way. Why I'm talking about clinical evaluation both in the surgical end and even in the restorative end is because implants depend upon something called as osteointegration. So osteointegration is a very integral part of implant dentistry, in which you're going to place an implant and the success rate depends upon your protocols and the concepts of clinical methodology you're going to carry over for your treatment aspects. And that way, you are going to give a restorative value for it. Again, you have to evaluate your patient in a restorative concept. The triangular triage is an important phenomenon. This eases your patient and gives an intense knowledge for planning the case well in advance. Helps for the treatment options, what you're going to give it to your patient, and as well as your patient is well informed with a complete knowledge of the treatment final outcome. Never give false promises as any other medical profession. Like I'll just give you an example.
Sorry, Dr. Altaf. Sorry, apologies again. I think there is a lot of disturbance in the clarity of the volume. Could we please try without your headphones and talk directly into the mic if you don't mind, please?
Disconnect my headphone, I think so.
Yeah, please.
This is can you hear me now?
Much better. Thank you. Much better.
Dr. Ali?
Yeah, yeah, I can hear you. Can you hear us? Can you hear me?
Can you hear me?
Yeah, we can. We can, loud and clear.
Dr. Ali?
Yes, yes, Dr. Altaf, we can hear you. Dr. Altaf?
Can you hear me? Hello?
Yes, yes, I can hear you. Can you see me? Can you see me? Yes, I can hear you. I can hear you. I can hear you.
Can you hear me? Okay, good.
Yeah, yeah, better. Thank you.
When we are talking about the triage, again, see, when a medical doctor, he takes up a surgery and plans a treatment, he will never give an 100% assurance to the patient that he'll be alive or not. The reason why I'm telling you this is because dentistry is less in problems with any other medical profession. There's less death rates. So to understand this, we have to value our profession. To value a profession, you have to understand that an implant dentist cannot give you an assurance of 100% outcome when a medical surgeon does not give you a 100% result. So rest assured, but following the entire protocols and the procedures, I feel that assure the patient, but not to the extent it's 100%. And remaining is left to Allah subhanahu wa ta'ala to help everybody to have a successful treatment outcome. Mish et al. Has classified the quantitative treatment aspect depending upon the scale, qualitative scale. That is 1 to 3, which is very feasible. That is with the optimum health, secondary with the satisfactory health, and third is the compromised health, in which we use the bone grafting procedures and all. And more than that, if the qualitative scale goes from 4 to 5, which is absolute clinical failure, and and 5 is totally it's a failed case, and there is no chance of maintenance, and main thing is the outcome is not there. So why I told you this scale is because entire thing is a triangular concept again, because this totally depends and revolves around the patient's maintenance, from the surgical aspect to the restorative aspect. After the lab fabrication also, the patient has to believe. We are going to take the patient concerns from starting to end. After the post-prosthetic also, we are going to take the patient's satisfactory guidelines and signature. So the necessity for this was very important, because a lot of cases have come down regarding the implant failures due to the patient's mistakes and maintenance. So now going to the concept of clinical examination, diagnosis, treatment planning, it's very important that we have to, first of all, do a proper clinical examination, medical health examination, dental x-rays, diagnostic criteria, whatever is there, we have to take it before well in advance. Same like any other procedures, what you do in your day-to-day dental practices. Photography is almost very important for you to record the case and to show the patient as well, to understand for his future benefits and for the benefit of the doctor also, with the patient's concern. So, and then evaluating the systemic factors. When you feel that the patient is diabetic and he's got some endocrinal disturbances or anything related to bone and the bone deformities, you have to take those things into consideration. Diabetes, HbA1c values up to 7, up to 8 also, according to the FDA norms and the WHO norms, have been reported as good. Okay, and then radiographic access to, why do you have to take radiographs? Radiographs for the bone quality and health, incisive cervical bone dimensions, distance between the adjacent teeth, caries, pulpon, and the periodontal health. If the periodontal health is not good, you will not be taking up that case for implant. After you do all the regular procedures with your oral prophylaxis and other root form procedures and all, that area which is next to the implant, even a single tooth implant, first do the oral prophylaxis and then take up the case. Now, after this, the main criteria for diagnosis is a concept where you have to take an orthopentamogram, a panoramic graph. See, the imaging concepts are divided into 3 phases. Phase 1, which is a pre-prosthetic implant imaging. Phase 2 is a surgical and interventional implant imaging. Phase 3 is the post-prosthetic implant imaging. So every step requires a radiograph, both surgically, after the restorative procedure, before the restorative procedure, and because of we have got a wide range of concepts which can be easily helpful for us for diagnosis. So the panoramic radiograph, it is used to depict the bone, the body of the mandible, maxilla, as well as the lower one half of the maxillary sinus in a single radiographic image. And it gives you the entire details of the anatomical landmarks, and as well as it gives you the sinuses present and the vital structures which are necessary. Then we take a IOPA, that is the RVG or intraoral periapical radiographs, which are limited in the region of the maxilla or mandible in a segmental concept where it is 3 to 4 teeth or 5 teeth are involved, which can be easily taken in a dental office. And long cone or 1:1 technique avoids the distortion of the limit magnification to less than 10% millimeters to radiographic grid. Then coming to the CT dental scans or the computed tomography, which is a 3-dimensional axial image of the patient's anatomy. CT images inherently are 3-dimensional, which gives you the total value of the anatomical structure in all the 3 planes. And it is divided and it enables the identification of the disease, planning, recording, and as well as knowing the bone quality. Identification of the critical structures gives the positioning and orientation of dental implant positions. And CTs are more used for the guide purpose and making the surgical guides or surgical guides for the surgical procedures, and are very important in the implant dentistry. But because of the cost factors, the CTs can be taken pre-prosthetic, pre-surgical, so that phase 1 is very evidential for us to take a CT scan. Then the reason for why you have to replace a single tooth when there is a missing single tooth. There are various options for the patient. You have to explain all the options. Then only go for implantology. Not all the cases are for implants. You have to remember that removable partial dentures are there, resin bonded prostheses are there, face maintenance are there, fixed partial dentures are there, and coming to the implant supported prosthesis. As I've told you, there are lots of advantages in benefits in implant dentistry for placing a single tooth implant for the preservation of the bone and regeneration of the soft and the hard tissues. So this was a case of a single lateral incisor with the bone deformity occurred after the 6 months of the tooth being extracted, and simultaneously it has been seen that the bone was again regenerated and it has formed nicely with a good emergence profile of the lateral incisor, and the case was very nice. So what are the advantages again when you use a single tooth implant? See, the information today is there in all the media and as well as in the at the tip of the hand for all the patients as well as the doctors. But the thing is, you should never be a Google doctor. Always rely on the procedures which you are going to do it at your clinic, as well as the evidence-based. how many articles have been published on the concept has to be told to the patient so that the patient will understand and go for implants, and he will save his bone as well as his structures and aesthetics. So I have already informed you about the single tooth advantages. The advantage is the less risk of caries because you're not going to cut an adjacent tooth, you're not doing an endodontic procedures, or you're not going to use a porcelain, extra porcelain for those crowns, and the less risk of uncemented restoration, overhanging restoration, less fractures of tooth, and moreover, psychologically, the patient will be at well-being that he has not lost his tooth naturally, and he does not have to splint his tooth, and he will not be losing his sensitivity on the remaining teeth. Improved hygiene conditions, that is, he can do flossing, he can use that crown or the pontic overhangs, but it will be very good for him to maintain the occlusal forces also. So decreased cold or contact sensitivity because you have prepped the two more teeth for making a FPD. And when you are doing this FPD, the cementum to the tooth also is removed during preparation. So, and then toothbrushing becomes easy and improved aesthetics, maintenance of bone. As I told you, as the years advances, the first year of loss of bone is 10% and then 30% decreasing according to the 3 years after extraction. So you can inform the patient and tell him to replace a single tooth because you will be avoiding the mesial migration of some of the teeth which are there on the adjacent teeth. So the anterior single tooth implant studies have shown a lot of good reports, like the Gomez-Roman et al. In 1996 reported that 96% overall success rate was seen. And Mish et al. Kalmish et al. In 2005 reported it was a successful rate for 98.6, which was the survival rate. And Zarona et al. In 2006 reported 97% of survival rate. When this is the concept, when people have shown that 10 years follow-up and the studies have shown that these are the surveys what they have done on hundreds of patients and thousands of patients, this is a successful and predictable practice. So it is a uniform concept where you can do implant dentistry with your total ideas of keeping the knowledge of implant dentistry in a proper decorum to help the patient for his success and for his maintenance and his aesthetic outcome. Now going to what is the available bone you want? All the implant dentists around the globe without a bone cannot do an implant surgery. So always when you are extracting a tooth, please be assured that maintain the bone and extract the tooth in such a way that all the areas three-dimensionally should be maintained. So there is periotome extractions which have been done regularly by the implant dentists or the oral surgeons today. They preserve the bone so that the future of that bone can be for implant placement. So considering the available bone, describe the amount of edentulous area considering the implantation. Bone is measured not only in the width, length, height, and angulation. The width of the bone always, when you see any of the missing tooth, you can see the bone loss occurring from the faciopalatal, and slowly it will have the crestal of the bone becomes a peak shaped or it will become a sharp edges. So you will not get an ideal cases for implantology always. So rest be assured, if the width is good, your implant placement also can be good. That's why we are using the tapered implants, aggressive thread implants, so that it can penetrate from the crestal to the lengthwise. So then coming to the width of the implant between from the crest, you have to see to that between the implant and the tooth, you have to maintain 1.5 millimeters from the natural tooth. This is always a protocol to be followed. Lesser than that will cause a problem for you. So always maintain the width and the dimension with mesio-distally 1.5 millimeters. So when the width or the ridge has collapsed and it is sharp, you can reduce the ridge by doing an osteotomy procedure, just grinding the ridge and flattening the ridge so that you get a better table for your osteotomy procedure. Then going to the length, with a greater surface area of implant bone contact, less stress is transmitted to the bone. So improves the implant prognosis. So always when we see the first molar is the tooth which is commonly lost at the age of 25 years. And it's the first tooth which is erupted, and it's the first tooth which is lost from 25 years to 40 years of the age group. And the adjacent tooth, the second molar, easily drifts. So we will not have an available width or the mesio-distal dimension for placement of implants. So always educate your patient so that the patient will understand and will say that, okay, we'll go for an implant as soon as possible. So it is a procedure which can be followed. Then the length of the implant is always determinant on the vital structure, like the inferior alveolar nerve, the mental nerve, and the mental foramen. Should be very careful, even the sinuses. So the reason why I'm telling you this is 2 millimeters of surgical space should be kept away from these vital structures to have a positive outcome, or then you will be damaging the nerve, as well as you're going to cause paresthesia, and you may cause problems for a lot of patients. So always be in the safer zone. Safer zone is to keep 2 millimeters away from the vital structures. Then coming to the height of the bone, minimum height for endosterial implants depends on the density of the bone. So you have got an outer covering of a cortical bone, inside will be a trabeculated bone. So more the dense the bone accommodates, means it is a shorter implant you can place. You cannot go and do a lot of osteotomies for a where the bone is D2 and D1. D1 we rarely get it, but D2 bones, there are very thick compact bones from top to bottom. In certain areas of mandible, we see this in the posterior areas of mandible. So you should avoid the length, or you should go for a shorter and a wider implant so that your surface area of the bone to implant contact becomes good, and the safer height for your implant placement. And if it is a D4 bone, means the bone which is soft and trabeculated, where you're getting the primary stability you will not get much of primary stability, then you have to increase the length of your size of your implant. It may go up to 13 millimeters. So, and then going to the angulation. Angulation is a very important phenomena. This is again, you have to see that wherever you're going to place an implant, it should be at the axis level, and ideally bone is perpendicular to the plane of occlusion and should be parallel to the long axis of the prosthetic restoration. Incisal occlusal surfaces follow the curve of occlusion and curve of Wilson, curve of C and curve of Wilson. So the maximum anterior teeth are only segment in the either arch which do not receive the long axis load because of the overjet and the overbite. Instead, it is angulated at 12 degrees. So the angulation concept, as we go in the anterior segment, it's 12 degrees, because what God has made on the facial palatal, where the natural teeth hold, is just 0.5 millimeters to 1 millimeter of bone on the central incisors and the lateral incisors, mostly on the central incisors, and it is placed more facially. You cannot place the implant on the same level. You can place the implant little bit palatally by creating an osteotomy which is away from the natural position of the natural tooth. So you should be away from it, and you should be more practically oriented, so that once you place the implant palatally, the angulation should be such a way that you should achieve a proper overjet and overbite of 1 to 2 millimeters, 2 millimeters to 2.5 millimeters in an implant dentistry. So it's always safer and it's always better. And going to the premolars, it should be 10 degrees from away from the facial aspect. And first premolar, it should be 15 degrees and 20 to 25 degrees in the second molar. So always maintain this. The reason for this is because more you go palatally, the achievement of bone on the facial surface will be more, and the accommodation of the biomechanics will be good. So this was earlier discussed in the Dr. Fayaz's presentation, that when we are talking about the case of implants, we should always have certain limitations. Not every case is for implantology. You have to think that what you're going to do with the limitations, what you get. The minimum age for the patient is a very important concern. So maxillary incisors will move 1.5 millimeters per year downwards during the active growth of 7 years to 10 years, and 0.1 to 0.2 millimeters per year up to age of 18 years. So it is, clinical reports have shown that when we place an implant at the age of 7, it moved 10 millimeters apically after 9 years, so 16 to 17 years. And in implants which were placed at 12 years, you could see there was 7 millimeters of infra-occlusion. So it was moving away from the where the final prosthetic was to be there. The size of the child is very relevant for implant insertion, because the patient should not have grown for 6 months. You have to see the cessation of the growth. If all the 4 criteria, means the age has finished, age has ceased, the skeletal maturity indicators are there, you can take a left hand wrist X-ray and you can see that there is a total fusion, or the SMI 9, which is there given by Fish and Fish, was was given, and where there is a bone which was formed, or there was an ossification finished, and the growth has been ceased, then you need go for placement of implant. Please don't go for procedures for your for any of the kids, or wait for the age to be there, and maintain the space with the other procedures of giving a single tooth replacement. So the chronological age is important general rule. What you have to follow is implant insertion in the anterior maxilla should be delayed. For females, it is 15 years. For male patients, it's up to 18 years. And you have to check the endocrinal changes. The female patient should attain the puberty. The male patient should have body hair, and there should be voice changes. And moreover, you take a left-handed X-ray and suggest the patient for a future procedures. Always give a temporization before you go for an implant procedure. So, and then coming to the, what is that very important when you are placing an implant in the anterior segment? You have to follow certain aspects. See, natural tooth is 4.5 millimeters to 7 millimeters in mesio-distally, up to 10 millimeters in the central incisors. When you do a cross section, the implants are round, whereas the tooth is conical and it is little bit curved. So it will fulfill the criteria of the mesio-distal width. What the God has made is totally different than what the implant, what we are going to place. So to achieve a proper outcome, you have to have a safer distance measured between the implant to the tooth distance, and as well as from the facial to the implant distance, facial or a buccal or a labial to implant distance. Again, it is 1 to 1.5 millimeters. And then if you are placing an implant of 5 millimeters, the mesio-distal should be 8 millimeters. You should achieve 1.5 on the, from the tooth to the implant distance. So 1.5, 1.5, it will be 8 millimeters. So this way, you will achieve a good emergence profile. Okay. So challenging the aesthetic and planning the size of an implant for any case should be preferable challenge for you, and to do a procedure where it satisfies the patient and your final outcome. So it is difficult. Initially, you may have a lot of difficulties in doing in the anterior region, but my suggestion is always go for a first premolar, which is the safer zone for placement of your first lifetime implant if you want to place. So the crown height space, like in cases of bruxism and class 2 division 2 skeletal pattern with the inadequate maxillomandibular relationship, it is contraindicated. And the space between these two, because of the lateral occlusion or there is a cross bite, you should never do an implant in these type of cases. The reason for this is you have to first of all do an orthodontic treatment, first of all relieve that cross bite, and then go for the implant. Okay, or go for the procedure where you have to intra-occlusal space has to be assessed very carefully. You should have a proper dimensional stability for your crown. So always avoid when there is a case of bruxism, but you can do the cases, but after the other treatments should be followed and procedures should be maintained. You cannot place an implant when there is no mesio-distal space. You should always think of the prosthetic first. That's why wax up is more important. I'm going to come to that slide and explain you about it. But the thing is, the mesio-distal space is very important. You cannot place just an implant for the namesake just to maintain the bone. It is also for the aesthetic, and it's also for the functional value, also for the mechanical value. So please may see to that you have enough space for placement of implant mesio-distally, so that it should be 1.5 millimeters from the adjacent tooth. This I'm repeating again and again, so that your methodology of planning the treatment is nice and good. So coming to the bone height is always should be maintained, because this will depend upon your aesthetic also. So the bone height should be ideally 1 to 2 millimeters from the CJ. You have to measure these, and if the ridge is sharp, as I told you, you have to flatten those ridge and place your implant. In this case, we had to place a bone graft and then place an implant. Similarly, when you see the overdrapping of the soft tissue also is affected by if there is no bone height. Don't go for the procedures when there is no bone height and CJ is not more than, if there is a bone loss, it is not going to be effective for your implant procedure.
Dr. Altaf?
So, like as I told you, faciopalatal width, which is very important for your maxillary teeth, anterior teeth. So, the naturally what God has made this tooth structure naturally will be just 0.5 millimeters to 1.5 millimeter, 1 millimeter, which is towards the facial aspect. But when you're placing an implant, always go little bit palatally or gingivally, so that palatally, so that lingually, so that you will not be there, because there is a continuous loss of bone. So, and similarly, like your natural tooth, even there is a bone loss occurring in the implant what you have placed in the same position of the tooth. So avoid the placement of the same position of the natural root of the tooth. So go a little bit palatally, and you can do adjustments in your abutments, because you get angulated abutments also to maintain the overjet and the overbite. So you can adjust in that way by doing a proper surgical protocol. So that way you should always follow the surgical protocol, which is very important for your final outcome. Now coming to the soft tissue treating, the soft tissue which covers and overlaps, because see, all the cases which come to you, whether one is the bone loss, second is the soft tissue bone loss, soft tissue loss. The soft tissue loss in the aesthetic zone is more symptomatic and more problematic. So you have to see what level of damage you have got in this tissue area. So you have to plan the case, or you have, obviously you're going to place an endogenous implant which is placed subcrestally, or you can place a polished further implant so that you can achieve these type of facial values or the aesthetic values for your implant, or go for an FP2 or an FP3 implant. FP3 implants is with the ceramic which is coated with gingiva. So you can achieve those type of draping once you're not achieving the proper goal for your aesthetic area.
Dr. Altaf, can you hear me?
1.4 millimeter may cause bone loss and implant failure. So always be very careful when you're placing the implant in the anterior upper maxillary area. So coming to the canine root is angulated at 11 degrees, and the root, what you're going to see, has been angulated, and some of the roots are dilacerated also. So be very careful so that you should not cause a damage by your implant to the root surface. So there is a distal curve of 32% most of the time. So tapered implants are always advised, and at this area, on this junction, because it is from where the total convexity of your total occlusion turns up. So you have to maintain that tapered implant body at the apical 1/3 may be more beneficial. Always place the implant mid-crystally centered, and it should not damage the roots of the tooth. So coming to the wax up, how do you prepare this wax up? It's a general chairside procedure where you can just place the tooth size. You have got Premolar or any other companies which provide the natural acrylic teeth that can be placed on the model, on the working model, and it can be, you can judge yourself which implant, what size of an implant can be placed at that particular area, if it is a premolar, molar, and the molars. So always do a wax up. When you're starting your implant practice, my advice is please go for wax ups and surgical stunts regularly. So, and prepare the surgical transitional prosthesis, because if it is in the aesthetic zone, always prepare the transitional prosthesis, because the patient will never go out without any flippers or RPDs and the crown. So always in the aesthetic zone, please go for a transitional prosthesis. What are these transitional prosthesis? Once you have placed an implant, after that you have sutured it, the next day or the following day, you can give this flippers, and you can relieve this structures from down, so that it should not affect the tissue as well as the bone, and it should not have any occlusion forces onto the implant which is placed. So these are the certain transitional prosthesis which you can give it to your patients so that they will be happy in the aesthetic zone. So coming to the surgical template, before your surgery, plan this. This is a surgical template which is made with an orthodontic clear acrylic rapid repair acrylic, so that you can make.
Sorry to interrupt, Dr. Khalid. Can you hear me?
The heat cure also. You can give it to your lab, but always see to that it should not hinder your surgical procedures. It should not hinder your procedure when you're placing an on the outer area, so that it should just hold to the natural teeth in the adjacent area, so that this will give you an area where you can run your birth or the you can do your drilling sequence easily. So there are the different types. Again, what I'm showing you, this is regularly used by us, and it is very effective, and it's very good. Once you open the flap, there's a lot of blood, and once you keep this and just give a point drill, after point drill, this is not for much use. So you can go for this type of surgical templates regularly for a single implant placement and all. Because all the cases, if you prepare this surgical template, it is very helpful for your future, and it's very helpful for your procedure. You will not do any mistakes by doing this. So,
Dr. Altaf, can you hear me?
Tooth implant is implant implant location and alignment is it should be बोलो डॉक्टर.
I think you're not able to hear us. We are trying to unmute you.
Oh, okay.
We are running fast of time. I guess.
Oh,
Probably
okay.
we have 10 more minutes left.
मैं जल्दी करना क्या अब?
We have almost passed the point.
Exactly.
I think
It's also full with anyway. Okay.
Okay, what you can do is probably okay.
So sorry, again I'm back, and the guideline for a single tooth implant is implant location and alignment. It should be centeredly placed, and you have to place the implant in the center position where the axial load is directed towards the root and the apex of the implant. So the bone to implant contact also is good, and mechanical loading is also better. So avoid the injuries to the adjacent root. So this is a courtesy from Dr. Iyer's slide, which I have taken, and this was a mistake done by some of the doctors, because their placement of the implant should be always, actually you have to check for it, it should be straight and it should be parallel, so that it should not damage the adjacent root. So coming to the, again, the aesthetic will be compromised if there is a offloading, something called as when you place an implant not mid-crystally or in the centered position. What happens is there is a cantilever and there is the failure of the implant, even in the prosthetic. So always see to that from the CEJ 2 to 2.5 millimeters for the anterior segment or the incisors, and 3 to 4 millimeters in the posterior segments you have to put subcrystally. How I've shown you this case. So this was an orthodontic case because there is a bone loss when we are doing orthodontic treatment, and this was an external head space what we have placed, and it should always be away 3 to 4 millimeters, and or it should be 2.5 millimeters away from the CEJ of the adjacent tooth facially. So anterior biomechanics is to establish a lot of cases which we have seen in the anterior segment is you get a black triangle, you get a bone loss in the crestal area. See, normally 0.5 millimeters of bone loss, crestal bone loss is seen in the year of implant placement. That is normal. But the thing is, if it is exceeds because of the wound lodgement and the space between the prosthetic and the availability of the implant surface, it happens in such a way that there is a biomechanical failure, and ultimately that's why you have to place the implant in a mid-crystal area, so that middle area, so that center actually very parallelly centered. That's why you have to do a wax up before you plan the case. Whichever tooth you're going to place, do a wax up and then do it. And papillary releasing incisions are also there, but in the anterior region, you have to preserve the papilla before you do the procedure. And then implant was placed because see, all the cases are not natural because there is a bone loss and there will be a little bit of tissue damage when during the procedure of the surgery. But it can be organized in such a way that you can plan your case in such a way that papilla should not be affected and the midline should not be affected, and you can do the treatment in such a way that also in place an implant in such a way, and the prosthetic outcome also will be nice. So this is a case of 2 implants anteriorly of a patient who had come for us, and his when we opened up, so always don't do flapless surgery. Open up the flap so that you can see where you have gone wrong or how the bone is. So once we place an implant, the bone which is lost totally from the apex, we got the primary stability. What we did was we placed the bone graft and then we placed the membrane and then we sealed it for 6 months and then we followed it up after 6 months. And then we had given him a flipper for a few days with the soft liners from below, so that the patient will not harm the harnesses with implants which are placed. So then when we came for the second stage, we have placed the healing abutments, and then we have taken the impression copings and placed and taken the impression. This was the milled by the lab and was given back to us. See the papilla which is being preserved very nicely. So that this is the way you have to preserve the middle papillas or the midline, and as well as the papillas in the surrounding adjacent tooth. So this was placed, and see, naturally, mostly preferable is the PFM crown, but patients prefer for the anterior segment that should be a zirconia crown to be placed. But whatever it is, but place a nice crown which is important for the patient, and because there is not much of forces, so you can place a PFM crown also in the anterior segment or zirconia crown also. So this was the case which was finished, and both palatally and this was, and 5 years follow-up after that. Then coming to phase 2, which was a lateral missing, and he was on a temporary resin bonded tooth, which was temporarily maintained because of the implant placement. So then the implant was placed, and again we always take an IOP before the procedure and after the procedure, during the procedure and post-prosthetically. And then the implant was placed, and then final result, the lateral maintained lateral. So always think of doing during the abutment, the prosthetic placement, do the torquing properly according to the concept given by the companies. So and do a proper torquing before you place the final crown or fix it with the permanent permanent cement. So, and there is a crystal bone loss that can lead to peri-implantitis and shrinkage of the tissues and poor aesthetics. So always be careful when you are doing a single tooth implant. Be careful, and here the vital role is of the patient to maintain his oral hygiene and do it and maintain the oral hygiene for long time. And the parameters to decide the implant, again, it is for 2 millimeters below the CAJ. Ideal width should always be from 1.5 millimeters from the interfacial aspect, and naturally implant should be placed more palatally. See what happens in the aesthetic when the tissue is when the implants are placed in such a way and there is a bone loss occurring towards the ear. So, and there will be a compromise of aesthetics, and ultimately there is a failure of the implant. So posterior single tooth implant, again, there is inadequate bone volume, inadequate intra-tooth space, observable mobility of the adjacent teeth. So these all conditions can be overcome when you have a proper bone volume and you have got a good intra-arch space, or you have got adjacent teeth should be maintained with any of the other periodontal problems. What are the multi-center studies showing is the multi-center studies given by Bioris in 1999 said survival rate of 5 years is 100%. In 2006, Mish et al. Has said that 100% of success rate is there, and Godekre et al. In 1981 to 2003 that single tooth implant in the posterior can be very successful for 97%. So the very important is again the body correction or threaded implants provide greater functional stability and surface area than the cylindrical implants. And there are tapered implants, which I told you in the anterior segments with aggressive threads are always better and less surface area, and parallel walled implants than the parallel walled implants. So the tapered implants are more better than the parallel walled implants in the anterior region in the maxillary areas. Implant body selection, the ideal diameter of the single tooth implant dependent on the mesio-distal dimension. The implant site, ideal implant diameter is 1.5 millimeters from the adjacent tooth and 1.5 millimeters from the lateral aspect of the ridges. Rule, as a general rule, always think that the molar implant should be larger in diameter than the premolar implant. So posterior biomechanics is single crown should not extend laterally to the implant more than the one implant diameter. For a 4 millimeter implant, the maximum cantilever should be 4 millimeters itself, so that 2 millimeters from the either side. So most ideal tooth to replace the first premolar, as I told you, if you have to start your implant practice, always start with the maxillary first premolar, and the maxilla, it is anterior to maxillary sinus, and it's anterior to the mental foramen also in the lower mandible. So the bone and even the bone trajectory is more favorable in this tooth. So this is the first premolar case. So slight buccal placement improves the cervical emergence because there is the concavity of the after the canine contouring or canine prominence. Case 4, this is a molar implant which was placed. We always think of first of all prepare wax up, see the occlusion and maintain the occlusion. When there is a bone loss, there is a supra-eruption of the upper teeth also. So you have to manage these aspects when you are planning your first molar implant. So case 4, again with the molar, and see when I'm talking about what is that overload in the molars, because the most of the functional mechanical forces fall on the molar implant, and when there is a molar implant which is not properly placed in the center position, the offloading will be there, or there will be overloading, and where there is a cantilever which is extends more than the normal axial load, what happens is there will be a fracture of the implant. That is again Dr. Iyer's case, which is being going to be. And compensation of overload, how do you manage to compensate? If there is a big space between the first molar and the premolars, and the region you have to place, you can place a bigger implant if you get the bigger implant, or place 2 implants and give a single crown. Use 2 implants to support 1 molar. Use a wider diameter implant, always necessary. And even if you increase the length, the surface area of the implant also increases. So coming to the conclusion, always takeaway message from me is 1.5 millimeters radio facially to implant, 1.5 millimeters implant to tooth, 3 millimeters implant to implant distance, and 2.5 millimeters below the CEJ for anterior implants endosseously. Always take IOP radiographs after initial drills and to correct your angulation. Implants are prosthetically driven, so never ever do implants without planning your prosthetic. So do wax ups and surgical stents for all the cases, even if it is a simple one. Thank you, and this is the ideal implant diameter to replace the average size teeth. Central incisors 4.2 to 5.2 millimeters, lateral incisors 3 to 3.5, and canine is 3.7 to 4.2 millimeters. And thank you. I have taken enough time. I'm really sorry for it, and I had got lost into the presentation. So thank you once again for all the organizers. I will take up some questions if anybody wants to ask any questions.
Thank you, Dr. Altaf. I'm just going to unmute the panel members and Dr. Fayaz, and Dr. Fayaz would start, putting the questions forward. But thank you very much. It was a very fruitful talk. I do apologize again for the audio quality. Unfortunately, I think Dr. Altaf. Sorry, I think we can hear you now. Sorry, I think I lost a bit of.
I'll put that
headphones. That's brilliant. Dr. Arif, can you turn on your video, please? And Dr. Altaf, you can stop sharing your screen if you don't mind, and then we could just have a panel discussion where everybody is visible. Okay. Thank you. I'll leave it to all the 3 stalwarts of implants now to talk. Thank you. I'll mute myself.
Thanks, Ali. It was a great session. And you being a very good host. Alhamdulillah, all the presentations which you have given till now have been excellent. And Dr. Khalid, it was an excellent presentation. And we have fewer questions. I think Fayaz, you can just go ahead with the questions so that we'll try to maximally answer the questions with whatever knowledge we have.
Okay. Thank you so much, Dr. Arif, and thank you, Dr. Ali, and thank you so much for a great presentation, Dr. Khalid, as always. So it was very nice. You covered almost, starting from the, the basic of diagnosis, treatment planning till, what are the precautions we have to take, and including your final slide of giving a tip of important implant sizes we have to choose. Thank you so much for the presentation. But meanwhile, we have a couple of questions. We have Dr. Arif also, a trained implantologist and a fellow of AID, who will be also join here with us for answering the question. So I have a first question from Dr. Parvez. He's asking, implant dentistry right now, you said it is prosthetically driven, but he thinks, what is your point if it is aesthetically driven? So he wants you to clarify. So he thinks it has changed from prosthetically driven to aesthetically driven. So please clarify about this.
Okay. So the reason is, if there is no prosthetic, there is no aesthetics. It's vice versa. And mashallah, without aesthetic, what does the patient want? He wants the crown. He wants the teeth. He wants it functional. He wants for aesthetic. He wants for his psychosocial effect. So it is important that he should have a prosthetic. Then only he can see the aesthetic outcome. So it is prosthetically driven, so that aesthetic outcome is there for it.
Okay.
Sorry to interrupt, Dr. Khalid. Parvez, as you precisely said, a good question. Why can't we call implant dentistry as an aesthetic driven rather than prosthetic driven? What exactly is aesthetic you're talking about? Is it the anterior part of the oral cavity, or maxilla, mandible, or the posterior part? Aesthetic is nothing but you're trying to beautify somebody. So when you talk about aesthetic, it is the anterior zone which you're talking about. So when you are planning your case in an anterior maxilla or an anterior mandible, which is the most toughest part in implant dentistry, to place an implant and to place a crown, until you plan your treatment with a diagnostic wax up, with a CBCT, knowing exactly what amount of bone is there and where to place an implant, it is very difficult to achieve not only the aesthetic, but you will screw up the case by placing the crown in a very difficult position. So planning is very, very important. And what do you mean by aesthetic? Is it only the looks you're talking about, or it is a functional part of also? See, the patient who comes to your clinic will just ask for you to place a teeth in the front region. Whether to go for an implant or an FPD, it is the patient's decision, and how you convince the patient is what it depends. So once you take up the case, planning of the treatment is very, very important. Don't just rush into the treatment, place the implant in whatever position you want, wherever you feel the bone is, and then cut a sorry figure when it comes for the placement of the crown. So make sure yourself that you are placing the implant in the correct position and not cutting a sorry figure when it comes for the restorative part.
Okay, thank you, Dr. Arif.
If you want to continue something, you can continue.
Yes, and I would like to tell all our participants here that we have a lot of questions, and we'll also be very brief for answering all the questions. And just to add one sentence for what Dr. Khalid and Dr. Arif already told, being a prosthodontist, see, the basic definition of prosthodontics is replacement of any missing structure with form and function, functionally and aesthetically. So prosthodontics is replacing it for the form, function, and aesthetics. So there is no need of taking aesthetic as a separate entity. Prosthetically driven means it is function and aesthetics together. So we look into that kind of, it says in the basic definition of prosthodontics. So that's how we can take it. Also, I'm moving to the next question. The next question is by Dr. Nair, I guess. Yes. So Dr. Nair asks, management of profile in ceramic implants in patients with alveolar protrusion. So he wants to know how to manage the profile if we are using ceramic implants in the cases which we have alveolar protrusion, or maybe labial protrusion. Okay. So any one of you can take up.
Okay. The reason is I have not done any ceramic implants till now, but the thing is, whatever you place, you have to plan your prosthetic again. So once the final outcome is there from your prosthetic value, will give you, I don't think so ceramic implants or any other implants will give you the same result. So in this, if there is a thick biotype of gingiva, thick biotype is a problem. If it is a thick biotype, then you can go for normal implants, that's titanium implants. Or if there is a thin gingival biotype, then you can go for a ceramic implant. But the result is the same. Prosthetic, what was your planned and placement of your implant and profiling and everything is the same. So this is my answer for it.
Yeah. Just to add, I think Dr. Nair has asked a very tricky question. So
Yes.
he's trying to tell the zirconia implants are one piece. And you have a labial protrusion also as a challenge, and how we are going to manage the profile. That's what I think he's asking. It's a very intelligent and tricky question he has asked. We know that zirconia implants are one piece. We don't have any freedom of angulation when it comes to our prosthetics. So that's where we go for two-piece like implant and abutment in such cases. But if aesthetic is a priority, probably I personally would place titanium implant and choose a zirconia abutment to mask the aesthetics, or maybe put a titanium implant submerged 1 mm below the bone and then use a zirconia abutment, and probably you can get that good profile. So probably other modification would be during surgery. You can modify a bit of bone and angulate the implant. Think of bone modification techniques, you can use it. So I think that's about it. And as far as the labial protrusion is concerned, we always look into the angulated abutments. That's where again pre-prosthetic treatment planning is so much important, as Dr. Khalid was mentioning in the presentation. So we'll move on to the next question. So next question is by again Nair. Dr. Nair asks, patients with thick gingival biotype, what level do you prefer placing the implant? I think if there is a thick gingival biotype, so what's the level you prefer placing the implant?
Okay. So here the question is where you want, first of all, endoosseous implant should be submerged inside the bone. So, and then depending upon the tissue, if there is a thick biotype, one is the end result. When you see the scallop margins of the adjacent tooth, you can do a gingival surgery or gingivectomy procedure to accommodate the same type of crowns in the adjacent tooth. So you can do surgery in the post-op also if there is a thick biotype.
Yeah, adding to something to this, what exactly does thick biotype suggest? It suggests that there is a lot of keratinized tissue, the health of the gingiva is pretty good, and the amount of available bone inside is also pretty good. So based on this, which area of implant are you placing? Is it the posterior implant or an anterior implant? When it comes to the anterior implant, you should be very careful, and you should, as Khalid has already told, the placement of the implant should be at least 2.5 to 3 mm below the CAG of the adjacent teeth, which gives a very good emergence profile. So when it comes to the anterior part, the emergence profile plays a very, very important role. Posterior, I think if there is a thick biotype, just placing the implant at the crestal level is more than enough. Whereas when it comes to the anterior, you get a very good emergence profile. I think it's always better to place an implant as a normal protocol to 2.5 to 3 mm below the CAG of the adjacent teeth. Fayaz, if you want to add something, you can add.
I think you have answered the question. Only one thing I want to add is I am very scared about thick gingival biotype in smokers. That's
Absolutely.
What scares me when I do the cases. If a smoker with a thick gingival biotype, especially in the maxilla, that really scares me to go ahead and place the implant. Okay, we'll move on to the next question, and next question is by Dr. Nadeem. Dr. Nadeem wants to know the protocol for placing implant during orthodontic treatment. When there is active orthodontic treatment, what protocol can we follow for placing implant in such cases?
Yeah, Dr. Nadeem, it's a very good question, and the reason is I'm an orthodontist, so this question is like you have to finish the case and maintain the space of the implant to be placed, or in the mid of your treatment when you are into a rectangular wire, that time you can place it, because that will be a rigid fixation, means it is very well established with the lace backs behind. So that way you can do it in the mid of the treatment or the end or the finishing of the treatment or post orthodontic treatment. You can do it, but there is a bone loss surrounding the orthodontic treatment. So you have to camouflage it, means you have to plan it when you're going to do it. So it is, there are two schools of thought again. The reason why I'm telling you now is that the thing is you should do this post-operatively. It's always better, post-orthodontically, after you have placed your retainers and all this thing. Because there will be an access for you to do the surgery and to place the crown, to take impressions. Anything Dr. Arif wants to add?
You are an orthodontist. You are a better speaker for this.
Yeah. Okay, thank you for the answer. I just want to add one sentence to this. Whenever there is space, especially we do get cases where some missing laterals are there or some missing canines are there, and there'll be orthodontic treatment, and orthodontists come to us and ask, there is a space. How do you, going to manage this? But generally, we implantologists prefer we do it, as Dr. Khalid said, we do want to do it after the orthodontic treatment. But I think I'm not an orthodontist, but I understand that there are two basic movements in orthodontics, that is tipping of the tooth or the bodily movement of the tooth. So we advise orthodontists to only the tipping movement during their treatment. Don't do the bodily movement, so that your tooth root will come into the space where we have to replace the tooth. So we can't place the implant there. So that's one thing which we always want to do. Second thing is we want to put a small pontic there. It's called as riding pontic during the orthodontic treatment to maintain the prosthetic space. This is what things we
if you don't mind, can I answer this? Like, the reason is why I told you is post orthodontics and post at the end of the procedure during the finishing rectangular wires. The reason is that time the torquing is done, so the roots are leveled. The roots are at one level. So after that, there is no movement. So you're just going to go for finishing and detailing. That is just correcting your overjet, overbite, and all these things. But what we can do is we can just give a prosthetic crown and attach a bracket and place that tooth, missing tooth, for the aesthetic reason of the patient. This is also one type of provisional for the patient. And because the procedure of implant is a surgical procedure, so you have to take impression, you have to do a lot of other procedures. So it's always better to do it after the surgery. It is not during tipping or torquing. This after the torquing only, after the finish of the treatment. It's always better to do it after the procedure is done, orthodontic is done.
Okay. Okay. Dr. Nadeem just wants to add that you cannot have a tipping movement in
for the cases of orthodontics, I prefer to keep the for osseointegration or for the second this, you have to go for second stage surgery, or for a prosthetic, give more time, because the bone has to form there. Even after you have placed the implant, wait for longer time in orthodontic cases.
Okay, that's nice, Dr. Khalid. Now we'll move on to the next question. Next question is by Dr. Dania. Dr. Dania wants to know use of laser lock implants in aesthetic zone to reduce bone loss and soft tissue adaptation. What's your view? Kindly opine. It's about laser lock implants in the aesthetic zone.
Yes, you have used a lot of laser locks, I think so.
Yeah, I mean, I have used a couple of laser lock. Actually, laser lock concept came, I guess, around 8 to 10 years back, where it was introduced by BioHorizon implant system, where what they did is at a collar of the implant, with the laser technology, they made a very cell size holes on the implant surface, so that soft tissue can grow over it, and the soft tissue or the connective tissue can lock it there. So the first time in the whole of implant industry, they claimed that there is a soft tissue integration along with the hard tissue integration. That's what the laser lock implants became famous in the market. They marketed it like this. So again, when I see now after 10 years or 8 years, there are many studies. Some studies say there is 1% more success rate compared to the regular implants what they have, and some studies claim that there's no much difference or something like that. Again, it all depends on how we manage our hard tissue and soft tissue, and implant success. We understood now that it depends on many factors. It's multifactorial. Implant success is multifactorial, but laser lock implants do have a bit of advantage when it comes to soft tissue adaptation, because they can go and adapt more closely as possible as compared to the machined collared surface in the conventional implants. So probably a small percentage of advantage we can see with the laser lock implants. But again, on the other side, if you want to use in the Indian scenario, they are quite expensive compared to the regular implants. That's the biggest disadvantage I see with a lot of dentists. placing the implants. Only practitioners who are placing, higher quality or more costlier implants, they do take up. I had a chance to do a couple of cases, but in my experience, it's almost the same, I feel. But again, as the literature says, there is a 1% increase in the success rate in long-term studies. That's what
I think according to my experience, Fayaz, it doesn't make much of a difference whether you're using a laser lock implant or a regular implant. It is the position of the implant which plays an important role. Where exactly you're placing the implant, to what amount of level you are maintaining it. See, depending on that, you can place a temporary crown, you can build up the soft tissue accordingly, and then come back after 3 or 4 months and then place a permanent crown. So I think it's just a marketing strategy by the biohorizon people that they claim that it is better for a soft tissue, which I don't think so it is. Whereas regular implant, what we can achieve by regular implant is same is achieved by the laser lock. That is what I feel.
Yeah. Thank you, Dr. Arif, for adding it. And next question I'll move on to, it's again by Dr. Danya. Quickly, if unintentionally we hit the adjacent teeth during placement, what to be done if such complication happens? Please opine.
Please take out the implant, detorque it, remove that implant. So that's why you have to take X-rays before and detorque that implant, remove that implant, and put it in the safer aspect and redirect that implant into a safer. If you hit that implant, it's not going to fail.
There are certain studies regarding this. If you are hitting an implant, like the implant you have placed is hitting the adjacent teeth, the first and foremost would be, as Dr. Khalid told you, to retrieve it and redirect it. If you would have followed the surgical protocols perfectly after every step, after every drill, this complication would not have happened. But if it has already happened, and you see that you have placed the sutures, and then you take the X-ray and you see that the implant is touching the adjacent teeth. If the implant is having a very good stability, some studies say that you can do the endo treatment of the adjacent teeth and just watch for it. Otherwise, I think, as Khalid told, retrieve it and redirect it and place it back in the correct position. Fayaz,
yeah,
anything to
thank
add?
you. I just want to add one sentence regarding this. There is a whole of protocol regarding placing an implant very, very close to the adjacent natural teeth. We know that there is a thumb rule of 1, 2, 3, where we know that 1 mm of bone should be there and implant should be away 2 mm from the natural teeth. And if you're putting 2 simultaneous implant, you should be 3 mm away. So at least you should be 2 mm away from the natural tooth. That's what the protocol is. And by chance, if you are less than 1 mm, there is a protocol called wait and watch. You have to wait and watch for the natural teeth. If it's showing some symptoms, if you have, encroached the periodontal ligament space of the adjacent teeth or something like that. In some patients, you can do a root canal treatment if they say there's a lot of pain or periodontal ligament, injury or something like that, which gives tenderness. Intentional root canal you can do and solve the problem. If you really hit the tooth and if there is too much pain, then that's when the problems will start. So that's why Dr. Khalid has mentioned already that taking a check radiograph is very, very important after putting your paralleling pin so that you don't go wrong in your direction. If you have doubt, change the angulation and take it, but make sure you're at least 2 mm away from the adjacent natural teeth. This is the protocol we generally follow for the adjacent natural teeth. Then I'll quickly move on to the next question. Next question is by Dr. Shiraz. Dr. Shiraz Khadir. So Dr. Shiraz asked, if there is an infected tooth with draining sinus, what is the protocol for placing immediate implant? Doctor wants to know, you want to place, extract the infected tooth with draining sinus and then put an immediate implant. Is there any protocol?
Yeah, there is a protocol, but see, the thing is, if it is too much and it's much infected, it's better to go for after 3 months, after 2 months. So, but the thing is, you can cure it if it is less and the sinus is not draining out much. You can cure it, you can do bone grafting and place the implant.
Yeah, we can place an implant, curate it nicely, see to that there is no any granulation tissue, reflect the flap, see if there is any distance and fenestration or any loss in the bone. place the implant, place the graft, place the membrane, suture it, come back after 4 months for the placement of the restoration.
Okay, I'll move on to the next question. What is the, Dr. Shiraz Khairi again asks, what is the opinion of panelists on simultaneously using free gingival graft for every case in aesthetic zone?
I don't advise free gingival graft in almost all the cases, particularly in the aesthetic zone. If you have planned your case pretty well beforehand, in the first stage itself, you can rectify the gingival problem by placing the incision slightly on the palatal side when it comes to the anterior zone. If you have screwed up your case and if you feel if the free gingival graft is required, when you come for the second phase, that time also you can at least rectify by placing the incision slightly on the palatal side and bringing the carinized tissue on the buccal side. Even if that fails, then that is the one when we apply for use the free gingival graft, otherwise not in all the cases. Free gingival graft is not an easy procedure unless and until you are experienced in placing it.
Okay, that's too much of sensitive surgical technique. Okay, we'll move on to the next question by the same doctor, that the third question he has asked. And what are the chances of implant survival if there is a spin of implant due to excessive torque?
Why are you putting your strength on the implant? Shiraz, why are you putting your strength on the implant? Implant has to be placed into the osteotomy very gently. Why are you putting the implant an excessive torque? If it spins, if you find there is little bit of stability, I think you can bury the implant and come back after a few months. If you feel that spin is too much, I would advise you to remove the implant, place an implant with a slightly larger diameter, and then proceed further. Yes.
Dr. Arif, I just want to add this. What about excessive torque Dr. Shiraz is asking about? See, we generally torque the implant to a certain amount. And, what do we expect when we try and torque the implant excessively? This is what I want to know. And what is the maximum limit we can torque the implant so that, it will not break the bone? So these are all the questions which will come into mind. I think if you torque it too much and if the implant is spinning, that means the bone quality is low there. The bone is not offering resistance, for the implant. Generally, we talk about 40 Newton centimeter square. That's the top we want to put in, to achieve a good mechanical stability of the implant. Studies say that you can torque the implant up to 150, 200 also, where bone starts cracking or breaking. That's the maximum bone can take up. After that, it's so that's about it. So as Dr. Arif mentioned, if it is spinning, best thing is to take it out and modify the osteotomy and properly put a bigger implant. We'll move on to the next question. So Dr. Nadeem asks, you can, no, Dr. Nadeem has already given about this. Next, Dr. Muiz asked a question. If implants is not aesthetically placed, is it possible to move implant?
Sorry, Fayaz, you just skipped Dr. Basha's question.
Yes.
What points should be kept in mind when selecting a case for missing maxillary lateral incisor? As a general dentist, would you keep in mind?
No, that's after this.
What would you keep in mind? That's from
no, before that, Dr. Asim case is next. I'm coming into that. I'm asking Dr. Mui's question now. He is before Dr. Asim.
Are you sure?
Yeah. In my
did he send? Sorry. Okay, fine. Carry on.
Yeah, Dr. Asim has asked a question. I'll ask about it. So Dr. Muiz has asked, if implants are not aesthetically placed, is it possible to move implant orthodontically?
No.
No. The straightforward answer is no.
No. You cannot, because see, there is a certain concept which we have to understand in implantology is we are waiting for the osseointegration to happen. And once that has happened, you try to remove that also, it will not be easy to you to remove that. You have to use trafines and all these things. So this question, I don't know, I think so, it's not possible. After it's osseointegration. Or during the procedure, after the procedure, you can slightly change or redirect, but still you have to use the bone grafts and membranes.
Once an implant is also integrated, it is very difficult to change the direction of the implant.
Yeah, the straightforward answer for this question is no. They have already mentioned it. And because implant is anchored to the bone, we say implant will become part of the bone
Absolutely.
once they integrate. So
Absolutely.
we don't try this heroic efforts to move the implants. Once it's done, that's it. So next question, Dr. Asim Basha asks, what points should be kept in mind when selecting a case for missing maxillary lateral incisor? As general dentist, what should be kept in mind?
So the thing is, first of all, you have to, because I told you implant is prosthetically driven, plan a lateral incisor there, keep that, make a wax up, understand where the location of your tooth or the final prosthetic is going to come, and then check for all the diagnostic criteria, see how the bone is, and then plan your case so that you can place the implant in such a way that it should be, again, the mesio-distal should be 1.5 millimeters, 1.5 millimeters from buccal to facial to palatal. So all, from the implant and all. So these all criteria will be maintained, and if you can go through my presentation, I think so you can place any implant in any region. And
The first thing we should keep in mind is available mesio-distal
available
space. See, if you are having space between the mesio-distal width, you have less than 3 mm, I don't think so we can place an implant over there. So I think orthodontically we might have to create the space and then go ahead. The minimum width of an implant should be at least 3 mm to get a good stability and a good emergence profile for the crown. So if you don't have a very good mesio-distal width available bone, I think it's very, very difficult to place an implant in the lateral incisor region. So you have to orthodontically create the space for placing of an implant in the lateral incisors as a general.
Dr. Nadeem Ahmed would like to speak or ask something.
Yes. Assalamu alaikum, to the panel member, to the moderator, and to the speaker. I have a question to Dr. Khalid. We have a case who is undergoing orthodontic treatment, who has already placed an implant, who has already been placed an implant around, say, 3-4 years back, lower 6 or bilateral lower 6, 4-6 or 3-6. Is it necessary to place TADs if we are planning for maximum anchorage case, or will implant serve as same as TAD per se?
Implants cannot be served as a TAD. So implants are totally different. This is for your prosthetically and mechanical loading. And whereas the TADs are for your, it's a temporary anchorage device that can be only used when you want your correction of your anchorage. Means you have to attain your anchorage loading or anchorage principles, then only you should use the TAD. So now if there is no molars at all, and you have placed 2 implants, that's the first molar and the second molar, you can use TAD distally to the second molar implant. And that is, it should be placed on the lateral aspect of the body of the mandible. And naturally taking, if there is a third molar, you can take an anchorage on the third molar and do the treatment also.
Is it contraindicated? That is what you're trying to say? The implant cannot be used.
TADs are totally different than.
Yeah, I do understand that. TAD is totally a different entity.
See, I've got a case. I can show you that case also. But the thing is, I have done the orthodontic treatment for that girl, and she had the molar missing, and we are in the finishing stages. Then we have placed TADs and we have placed the implant also. That case can be done simultaneously. We can do the case. It's not a problem.
Okay, so you cannot use the implant per se as the main anchor unit during retraction phase.
No, absolutely no.
Right.
Tooth with the implant, because the implant has got implant does not have periodontium, whereas the natural tooth has got a periodontium. It will fail your implant, and moreover there will be a drifting of the tooth also.
Thank you, Doctor.
More than the implant, your teeth just next to the implant will start drifting towards the implant. If you're taking the implant anchorage.
Right. Thank you, Doctor. Jazakallah khair.
Any other questions, please? I think we have done with all the questions.
Thank you very much, Dr. Altaf, Dr. Akmal, and Dr. Fayaz. This has been a wonderful session of question and answers. We would like to continue your questions. Unfortunately, if you haven't had the opportunity to ask questions here, please do type it out on our GDP group, and the recording for this talk would be available on our GDP channel.
Thank you, everybody, and thanks for giving this opportunity.
You have muted yourself, Mubarak.
Thank you, Ali, for being a wonderful host.
Sorry. You're welcome. Thank you all. Thank you.
Thank you, Dr. Ali, and thank you all.
Thank you all.
Jazakallah.
Jazakallah.